Question 1. A 55-year-old male patient with a history of chronic hypertension presents with sudden onset of severe chest pain radiating to his back and a feeling of impending doom. On examination, he is tachycardic hypertensive and has a difference in blood pressure between his arms. The patient's X shows nonspecific and segment changes. Which of the following is the most likely diagnosis and what is the immediate next step in management? A. Acute myocardial infarction. Initiate fibrinolytic therapy. B. Aortic dissection. Obtain contrast-enhanced CT angiogram. C. Pulmonary embolism. Initiate anticoagulation. D. Acute pericarditis. Initiate NSAID therapy. Answer. B. Aortic dissection. You obtain a contrast-enhanced CT angiogram. Explanation. The patient's presentation with severe chest pain radiating to the back, along with tachycardia, hypertension, and arm blood pressure discrepancies, is highly suggestive of an aortic dissection. Aortic dissection often presents with sudden, severe chest or back pain, and the difference in blood pressure between the arms is key clinical sign. The next step in management is to confirm the diagnosis with contrast-enhanced CT angiogram of the chest. This is crucial as it allows for the assessment of the aortic arch and its branches. Immediate medical treatment often involves blood pressure control with beta blockers and other medications aimed at reducing the strain on the aorta. Question 2. A 47-year-old woman with diabetes mellitus type 2 presents for routine follow-up. Her current HbAC is 7.8%. She has no history of diabetic retinopathy or nephropathy. Her current medications include metformin and sulfonylurea. Her blood pressure is 135/88 mm Hg and she is a non-smoker. Which of the following is the most appropriate next step in management? A. Increase the dose of metformin. B. Start an ALT inhibitor. C. Start a statin for primary prevention. D. Increase the dose of sulfonylurea. Answer. C. Start a statin for primary prevention. Explanation. According to current guidelines, patients with diabetes, especially those aged 75 years, should be started on a statin for primary prevention of cardiovascular disease if their 10-year atherosclerotic cardiovascular disease act risk is 10%. In this case, although the patient's blood pressure and smoking status are favorable, her diabetes and elevated HbAC place her at risk for cardiovascular disease. The addition of statin is appropriate to reduce the risk of myocardial infarction, stroke, and other cardiovascular events. Increasing the dose of metformin or sulfonylurea would not address the patient's cardiovascular risk, and where ALT inhibitors are beneficial for diabetic kidney disease and heart failure, there is no immediate indication in this patient. Question 3. Scenario-based. Mr. Thomas, a 62-year-old male with a history of chronic kidney disease, stage 3, presents to the emergency department with complaints of worsening shortness of breath over the last 48 hours. He has also noticed swelling in his legs and difficulty breathing when lying flat. His blood pressure is 145/90 mm Hg and his respiratory rate is 22 breaths/min. On examination, he has bilateral pitting edema in the lower extremities and crackles in both lung bases. His serum creatinine is elevated at 2.1 mdl. Which of the following is the most likely cause of his symptoms, and what is the most appropriate treatment? A. Acute heart failure. Initiate diuretics and ACE inhibitors. B. Acute kidney injury. Initiate dialysis. C. Pulmonary embolism. Initiate anticoagulation. D. Worsening chronic kidney disease. Start erythropoiesis-stimulating agents. Answer A. Acute heart failure. Initiate diuretics and ACE inhibitors. Explanation. Mr. Thomas' symptoms of shortness of breath, orthopnea, and bilateral pitting edema are highly suggestive of acute heart failure. HF, LICU with volume overload, is elevated blood pressure and kidney disease history increases risk for developing heart failure. The presence of crackles on lung examination and bilateral lower extremity edema further support. Diagnosis. The most appropriate initial treatment for acute heart failure with volume overload is the use of diuretics to remove excess fluid and ACE inhibitors to reduce afterload and improve cardiac function. Initiating dialysis would be inappropriate in the absence of life-threatening electrolyte disturbances or fluid overload unresponsive to diuretics. Question 4. A 70-year-old male with a history of hypertension and diabetes presents with complaints of fatigue, weight gain, and constipation. His laboratory results show an elevated TSH level and low free. Which of the following is the most likely diagnosis and the first-line treatment? A. Primary hypothyroidism. Initiate levothyroxine. B. Hypothyroidism, initiate methimazole. C. Central hypothyroidism, initiate high-dose levothyroxine. D. Subclinical hypothyroidism, no treatment required. Answer A. Primary hypothyroidism, initiate levothyroxine. Explanation. This patient's symptoms of fatigue, weight gain, and constipation, along with laboratory findings of an elevated TH and low free T, are consistent with primary hypothyroidism. The most likely cause of primary hypothyroidism is autoimmune thyroid disease such as Hashimoto's thyroiditis. The first-line treatment is levothyroxine synthetic for thyroid hormone to normalize thyroid levels. In central hypothyroidism, due to pituitary or hypothalamic dysfunction, there would be low TH, so that is less likely here. Subclinical hypothyroidism is characterized by an elevated TH but normal T, and treatment is typically not necessary unless symptoms are present or TH is significantly elevated. Question 5. A 35-year-old woman with a history of systemic lupus erythematosus, SLE, presents with complaints of a painful red, swollen knee and a fever of 101 dec. She also has malarash and recent positive anti-AN antibodies. Her ERP and ESA are elevated. What is the most likely cause of her symptoms and what is the most appropriate treatment? A. Septic arthritis. Initiate antibiotics. B. Gout. Initiate colchicine. C. Lupus flare. Increase corticosteroids. D. Rheumatoid arthritis. Start DMARDs. Answer C. Lupus flare. Increase corticosteroids. Explanation. In this patient with systemic lupus erythematosus, SLE, the combination of a painful swollen joint, fever, and positive anti-DNA antibodies is most consistent with a lupus flare. SLE can cause inflammatory arthritis, and in the presence of elevated CRP and ESA, it is more likely to be a flare of lupus rather than aseptic or crystal-induced arthritis like gout. Most appropriate treatment is to increase corticosteroids, which are the cornerstone of managing active SLE. Septic arthritis would typically present with more localized joint findings and would be confirmed by joint aspiration and culture. Gout would present with a history of uric acid crystals and is less likely in this context. Question 6. A 45-year-old male with a history of obesity, type 2 diabetes, and hypertension presents with fatigue, polyuria, and polydipsia. His HbAC is 10.2% and his creatinine is mildly elevated at 1.4 mg/dL. Which of the following is the most appropriate next step in his management? A. Increase the dose of metformin. B. Start insulin therapy. C. Initiate an ALT inhibitor. D. Start a thiazide diuretic for hypertension. Answer C. Initiate an ALT inhibitor. Explanation. This patient with poorly controlled type 2 diabetes, HbAC 10.2%, and signs of possible diabetic nephropathy, mildly elevated creatinine, would benefit from the addition of an ALT inhibitor. SLT inhibitors have been shown to improve glycemic control and reduce the progression of diabetic nephropathy. They also reduce cardiovascular risk in patients with diabetes. Increasing the dose of metformin may not be sufficient given his elevated HbAC, and insulin therapy is generally reserved for more advanced cases. Thiazide diuretics would not address the underlying issues related to diabetes and nephropathy. Question 7. A 50-year-old woman with a history of rheumatoid arthritis presents with morning stiffness and a tender, swollen wrist. RF and CP antibodies are positive and her ESA is markedly elevated. Which of the following is the most appropriate initial therapy for this patient? A. Methotrexate. B. Hydroxychloroquine. C. Prednisone. D. Infliximab. Answer A. Methotrexate. Explanation. This patient has a clear clinical and serologic diagnosis of rheumatoid arthritis, indicated by morning stiffness, joint involvement, REST-positive rheumatoid factor, RF, and CP antibodies. Methotrexate is the first-line disease-modifying antihemetic drug DMARD for RA and should be started promptly to prevent joint damage and improve long-term outcomes. Hydroxychloroquine is used for systemic lupus, erythematosus, and malaria, not for RA. Prednisone can be used for short-term flare management, but is not appropriate as initial therapy due to long-term side effects. Infliximab is a biologic and typically reserved for patients who do not respond to methotrexate or other DMARDs. Question 8. A 60-year-old woman with a history of hypertension and hyperlipidemia presents for evaluation of intermittent chest pain that occurs during exercise and is relieved with rest. The pain is substernal and lasts for a few minutes. She denies nausea, diaphoresis, or shortness of breath. Her vital signs are stable and she has A normal physical examination. X shows normal sinus rhythm with no acute changes. Which of the following is the most appropriate next step in her evaluation? A. Cardiac catheterization. B. Exercise stress test. C. Coronary artery CT angiogram. D. Start a statin and aspirin regimen. Answer B. Exercise stress test. Explanation. This patient presents with symptoms that are suggestive of stable angina, which is typically characterized by chest pain that occurs with exertion and is relieved by rest. The next appropriate step is to perform an exercise stress test, which is a non-invasive way to assess for inducible ischemia and to confirm the diagnosis of angina. Cardiac catheterization is not appropriate at this stage unless the test is positive or the patient has high-risk features. Coronary artery CT angiogram is an alternative, but typically used in specific situations where the diagnosis is unclear or in low to intermediate risk patients. Starting a statin and aspirin is beneficial for secondary prevention but does not address the need for diagnostic evaluation first. Question 9, scenario-based. A 72-year-old man with a history of chronic obstructive pulmonary disease, COPD, and coronary artery disease presents with increasing dyspnea, productive cough, and a low-grade fever. His pulse is 98 bpm, respiratory rate is 20 min, and oxygen saturation is 88% on room air. Chest examination reveals crackles at both lung bases, and his chest X-ray shows increased markings but no consolidation. Which of the following is the most likely diagnosis and was the first-line treatment? A. Community-acquired pneumonia. Start antibiotics. B. Acute exacerbation of OPT. Administer nebulized bronchodilators and corticosteroids. C. Pulmonary embolism. Start anticoagulation therapy. D. Congestive heart failure. Administer diuretics and ACE inhibitors. Answer B. Acute exacerbation of COPD. Administer nebulized bronchodilators and corticosteroids. Explanation. This patient's clinical presentation: dyspnea, productive cough, low-grade fever, and crackles, along with history of COPD, suggests an acute exacerbation of COPD. The chest X-ray showing increased lung markings but no consolidation also supports this diagnosis. The first-line treatment for an acute exacerbation of COPD nebulized bronchodilators, e.g. albuterol, systemic corticosteroids to reduce inflammation, and oxygen therapy to correct hypoxemia. Community-acquired pneumonia would typically present with more pronounced fever and consolidation on chest X-ray. Pulmonary embolism should be considered in patients with sudden onset of dyspnea and hypoxemia, but is unlikely in this context without additional risk factors. Congestive heart failure usually presents with more significant signs of volume overload and peripheral edema, which are not prominent here. Question 10. A 65-year-old male with a history of smoking, chronic bronchitis, and hypertension presents with increasing fatigue, weight loss, and a persistent cough with hemoptysis. His chest X-ray reveals a mass in the right lung with an irregular border. A biopsy confirms non-small cell lung cancer, SLC. The tumor is staged as ENMEM. What is the most appropriate initial treatment for this patient? A. Chemotherapy alone. B. Surgery with adjuvant chemotherapy. C. Radiation therapy alone. D. Targeted therapy based on genetic testing. Answer B. Surgery with adjuvant chemotherapy. Explanation. This patient has non-small cell lung cancer SLC with an AirTAGE, which indicates that the tumor is larger and has regional lymph node involvement, but no distant metastasis. The first-line treatment for resectable SLC in this stage is surgical resection, lobectomy, or pneumonectomy, followed by adjuvant chemotherapy to reduce the risk of recurrence. Chemotherapy alone would not be the best choice in this case because the patient has a resectable tumor. Radiation therapy alone is typically used for patients who are not surgical candidates or have more advanced disease. Targeted therapy is appropriate for patients with specific genetic mutations, e.g. EGFR mutations, but this would be determined by genetic testing and is not the first step in managing a resectable tumor. Question 11. A 56-year-old woman with a history of type 2 diabetes and hypertension presents for follow-up. She reports recent difficulty with urination, including increased frequency and urgency. A urinalysis shows significant proteinuria at 3, and her serum creatinine is 1.8 mg/dL, baseline 1 point or ADL. Blood pressure is 145/90 mm/Hg. Which of the following is most appropriate next step in her management? A. Increase her antihypertensive medication and monitor creatinine. B. Initiate a 24-hour urine collection for protein. C. Start an angiotensin-converting enzyme ACE inhibitor. D. Perform a kidney biopsy. Answer: C. Start an angiotensin-converting enzyme ACE inhibitor. Explanation: this patient with diabetes, hypertension, and significant proteinuria is likely developing diabetic nephropathy, which is a common cause of chronic kidney disease in diabetic patients. ACE inhibitors are the first-line treatment to slow the progression of diabetic nephropathy by reducing proteinuria and controlling blood pressure. Increasing antihypertensive medication is necessary, but ACE inhibitors or angiotensin receptor blockers (ARBs) are preferred due to their protective effects on the kidneys. A 24-hour urine collection may be useful, but it is not necessary to confirm the diagnosis in this case. A kidney biopsy is not needed unless the patient has atypical features or rapid progression of renal failure. Question 12. A 32-year-old woman presents with a 2-week history of a painful red rash on her lower legs. On examination, she has erythematous tender nodules on the shins consistent with erythema nodosum. She also has a history of recent upper respiratory symptoms. Which of the following is the most likely cause of her condition? A. Streptococcal infection. B. Sarcoidosis. C. Systemic lupus erythematosus. D. Tuberculosis. Answer A. Streptococcal infection. Explanation: erythema nodosum is an inflammatory condition that commonly presents as painful red nodules, often on the shins. It can be caused by various conditions, but in this patient with a recent history of upper respiratory symptoms, a streptococcal throat infection is the most likely cause. Other common triggers for erythema nodosum include infections such as streptococcus or tuberculosis, medications, and systemic inflammatory diseases like sarcoidosis and lupus. However, the patient's recent upper respiratory symptoms point toward a recent streptococcal infection. Sarcoidosis and lupus could cause erythema nodosum but are less likely without other systemic findings. Question 13, scenario-based. A 45-year-old man presents with progressive difficulty swallowing both solids and liquids. He also reports unintentional weight loss over the past few months. His history includes chronic alcohol use and smoking. Physical examination reveals a cachectic appearance and lymphadenopathy. An upper gastrointestinal endoscopy reveals a mass in the lower esophagus. Biopsy confirms squamous cell carcinoma. Of the following is the most likely risk factor for his condition? A. Gastroesophageal reflux disease (GERD). B. Human papillomavirus (HPV) infection. C. Chronic alcohol use. D. Barrett's esophagus. Answer: C. Chronic alcohol use. Explanation: this patient with squamous cell carcinoma of the esophagus likely has chronic alcohol use as a significant risk factor. Squamous cell carcinoma of the esophagus is strongly associated with alcohol consumption and smoking, which are major risk factors for this type of cancer. Gastroesophageal reflux disease (GERD) and Barrett's esophagus are more commonly associated with adenocarcinoma. Esophagus, not squamous cell carcinoma. Human papillomavirus (HPV) infection is linked to oropharyngeal cancers and some esophageal cancers, but is less common for esophageal squamous cell carcinoma. Question 14. A 74-year-old man with a history of coronary artery disease, hypertension, and hyperlipidemia presents with a complaint of intermittent claudication. He has been experiencing pain in his calves after walking approximately 200 feet, which improves with rest. Physical examination reveals absent pulses in both femoral arteries and diminished pulses in the popliteal and dorsalis pedis arteries. What is the most diagnosis? A. Chronic venous insufficiency. B. Peripheral artery disease. C. Deep vein thrombosis. D. Spinal stenosis. Answer: B. Peripheral artery disease. Explanation: this patient's symptoms of intermittent claudication, along with diminished pulses and risk factors for atherosclerosis, coronary artery disease, hypertension, hyperlipidemia, strongly suggest peripheral artery disease. PAD. PAD is caused by atherosclerosis of the arteries supplying the legs, leading to intermittent claudication, which is pain during walking that improves with rest. Chronic insufficiency typically causes swelling and varicose veins rather than claudication. Deep vein thrombus (DVT) presents with swelling, redness, and pain in the affected leg, but it does not cause intermittent claudication. Spinal stenosis can cause leg pain, but usually presents with back pain and is not typically relieved with rest in the way claudication is. Question 15. A 20-year-old woman presents with complaints of joint pain and a butterfly-shaped rash across her face. She has also been experiencing photosensitivity, fatigue, and oral ulcers. Laboratory testing shows a positive anti-nuclear antibody on a test with a titer of 1, 320, and a positive anti-double-strand ddNA antibody was the most likely diagnosis. A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Sjogren's syndrome. D. Dermatomyositis. Answer: B. Systemic lupus erythematosus. Explanation: this patient presents with the classic signs and symptoms of systemic lupus erythematosus, SLE, including a butterfly-shaped rash, photosensitivity, joint pain, and positive laboratory findings positive on and DNA. The positive on a test is common in many autoimmune conditions, but the presence of DNA antibodies is highly specific for SLE. Rheumatoid typically presents with joint involvement and is less likely to cause the characteristic rash. Sjogren's syndrome and dermatomyositis may have overlapping symptoms, but are less likely to present with positive DNA and the butterfly rash seen in SLE. Question 16. A 65-year-old woman with a history of hyperlipidemia, hypertension, and obesity presents with new-onset chest pain. The pain is described as a tight sensation in the center of her chest that radiates to her left arm. The pain started while she was walking up a flight of stairs and resolved after resting for 10 minutes. An electrocardiogram shows normal sinus rhythm without elevation. Cardiac biomarkers are normal. What is the most likely diagnosis? A. Acute myocardial infarction. B. Stable angina. C. Unstable angina. D. Costochondritis. Answer: B. Stable angina. Explanation: this patient presents with chest pain that is typical for stable angina, which is characterized by chest discomfort that occurs with exertion and is relieved by rest. The normal cardiac biomarkers and absence of elevation on egg make acute myocardial infarction unlikely. Unstable angina could present with more frequent or prolonged pain even at rest and often shows changes or elevate. Cardiac biomarkers. Costochondritis presents with localized chest pain that worsens with palpation of the costal cartilage but does not follow the pattern seen in this case. Question 17. A 45-year-old man presents with a 2-week history of fever, weight loss, and night sweats. He also reports a painful lesion on his left hand that has been progressively enlarging. His medical history is notable for intravenous drug use. Examination reveals a tender red fluctuant mass on the left hand. Blood cultures grow Staphylococcus aureus. What is the most likely cause of this patient's condition? A. Rheumatoid arthritis. B. Infective endocarditis. C. Herpes simplex virus infection. D. Osteomyelitis. Answer: B. Infective endocarditis. Explanation: this patient with fever, weight loss, night sweats, and a tender fluctuant mass on his hand is presenting with signs of infective endocarditis. I often presents with systemic symptoms such as fever and weight loss, and an intravenous drug uses. Staphylococcus aureus is a common pathogen. The tender lesion on his hand is likely a septic embolus, a complication of endocarditis where infected clots embolize to various organs, including the skin. Rheumatoid arthritis, herpes simplex virus infection, and osteomyelitis are less likely given the context of fever and a blood culture for Staphylococcus aureus. Question 18. A 72-year-old man presents with complaints of chronic cough and dyspnea on exertion. He has a history of smoking 1 pack of cigarettes per day for 40 years. On examination, he has decreased breath sounds and dullness to percussion in the left low lung field. Chest X-ray shows a pleural effusion on the left. What is the most likely cause of this patient's pleural effusion? A. Heart failure. B. Pneumonia. C. Lung cancer. D. Tuberculosis. Answer: C. Lung cancer. Explanation: this patient with a history of smoking and new-onset pleural effusion is most likely to have a malignant pleural effusion, especially given the chronic cough, dyspnea, and abnormal lung examination findings. Lung cancer, particularly non-small cell lung cancer, is a common cause of pleural effusion in smokers. Other potential causes of pleural effusion include heart failure, which usually presents with bilateral effusions, pneumonia, which would typically be associated with fever and productive cough, and tuberculosis, which is less common in this demographic unless there is a history of exposure. Question 19, scenario-based. A 58-year-old man with a history of diabetes, hypertension, and chronic kidney disease presents with increasing fatigue and generalized weakness. He reports that his urine output has decreased over the past few days. His laboratory results show a potassium level of 6.5 mecl, creatinine of 6.2 ddl, baseline 3.5 mdl, and a bicarbonate level of 6 mecl. Which of the following is the most appropriate management? A. Administer sodium bicarbonate. B. Initiate hemodialysis. C. Start intravenous insulin and glucose. D. Begin treatment with an ACE inhibitor. Answer: B. Initiate hemodialysis. Explanation: this patient is showing signs of acute kidney injury, with hyperkalemia, metabolic acidosis, and worsening renal function. Given his history of chronic kidney disease and the rapid progression of his renal failure, hemodialysis is the most appropriate next step. Hemodialysis is indicated in the setting of severe hyperkalemia, refractory acidosis, and significant azotemia as seen in case. While sodium bicarbonate can be used to treat acidosis and insulin glucose can lower potassium temporarily, dialysis is the definitive treatment for life-threatening complications of acute. ACE inhibitors are contraindicated in acute renal failure. Question 20. A 50-year-old woman presents with fatigue, joint pain, and a butterfly-shaped rash across her cheeks and nose. She also reports photosensitivity and oral ulcers. Laboratory results show a positive anti-nuclear antibody on an elevated double-stranded DNA antibodies. Which of the following is the most appropriate first-line treatment? A. Hydroxychloroquine. B. Methotrexate. C. Prednisone. D. Rituximab. Answer: A. Hydroxychloroquine. Explanation: this patient presents with symptoms consistent with systemic lupus erythematosus, SLE, including a butterfly rash, joint pain, photosensitivity, oral ulcers, and positive on an anti-DNA antibodies. The first-line treatment for SLE is hydroxychloroquine, which can help reduce the frequency and severity of flares, manage skin and joint symptoms, and provide some protection against organ damage. Methotrexate is used for other autoimmune diseases like rheumatoid arthritis, but is not first line for SLE. Prednisone is used for managing flares, but is not the first line for long-term management. Rituximab is reserved for refractory cases. Question 21. A 70-year-old man with a history of hypertension, hyperlipidemia, and smoking presents with sudden onset of severe tearing chest pain radiating to his back. His blood pressure is 106 to 9 mmHg in the right arm and 128 mmHg in the left arm. Physical examination reveals a new diastolic murmur. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Pericarditis. Answer: B. Aortic dissection. Explanation: this patient with sudden onset severe chest pain radiating to the back along with a difference in blood pressure between the arms and a new diastolic murmur is highly suggestive of an aortic dissection. Aortic dissection occurs when there is a tear in the aortic intima, leading to blood flow in the vessel wall. The difference in blood pressure between the arms is a classic finding. The other options are less likely to explain this combination of symptoms. Question 22. A 42-year-old woman presents with a 3-month history of progressive shortness of breath, orthopnea, and fatigue. She has a history of systemic lupus erythematosus, SLE, and was recently diagnosed with interstitial lung disease. On examination, she has crackles on auscultation of both lung bases and bilateral lower extremity edema. Pulmonary function tests show a restrictive pattern with decreased lung volumes. What is the most appropriate next step in management? A. Oral corticosteroids. B. Non-invasive positive pressure ventilation. C. Lung transplantation. D. High-dose intravenous cyclophosphamide. Answer: A. Oral corticosteroids. Explanation: this patient with SLE, interstitial lung disease, ill and progressive respiratory symptoms likely has lupus-related interstitial lung disease, which is treated with corticosteroids. Corticosteroids help control inflammation and prevent further lung damage. Non-invasive positive pressure ventilation is typically used for respiratory failure but is not the first-line treatment for ILD. Lung transplantation considered for end-stage disease, and cyclophosphamide is used in severe, progressive cases, but corticosteroids are usually tried first. Question 23. A 55-year-old man with a history of chronic alcohol use presents with confusion, ataxia, and nystagmus. He is also noted to have a wide-based gait and difficulty walking. On examination, his memory is impaired and he shows signs of disorientation. What is the most likely diagnosis? A. Wernicke encephalopathy. B. Alcoholic hepatitis. C. Hepatic encephalopathy. D. Korsakoff syndrome. Answer A. Wernicke encephalopathy. Explanation: this patient with confusion, ataxia, nystagmus, and memory impairment likely has Wernicke encephalopathy, a neurological complication of thiamine deficiency seen in chronic alcohol users. It is characterized by the classic triad of confusion, ataxia, and ophthalmoplegia. Alcoholic hepatitis primarily causes liver-related symptoms, and hepatic encephalopathy results from liver failure and is associated with altered mental status due to ammonia buildup. Korsakoff syndrome is a long-term consequence of untreated Wernicke encephalopathy and involves memory deficits without acute symptoms. Question 24, scenario-based. A 30-year-old woman with no significant medical history presents with a 1-week history of fever, fatigue, and a sore throat. On examination, she has cervical lymphadenopathy and a rash on her chest. A rapid streptococcal antigen test is negative, but heterophile antibodies are positive. What is the most likely diagnosis? A. Infectious mononucleosis. B. Streptococcal pharyngitis. C. Rubella. D. Cytomegalovirus infection. Answer A. Infectious mononucleosis. Explanation: this patient's presentation, including fever, sore throat, lymphadenopathy, rash, and positive heterophile antibodies, is most consistent with infectious mononucleosis, typically caused by Epstein-Barr virus. The negative rapid streptococcal antigen test rules out streptococcal pharyngitis. Rubella typically presents with rash and lymphadenopathy, but not with sore throat or hetero. Antibody positivity. Cytomegalovirus infection can cause similar symptoms, but is less likely to produce positive heterophile antibody test. Question 25. A 62-year-old woman with a history of obesity, hypertension, and type 2 diabetes presents with progressive shortness of breath over the past month. She has no chest pain or cough. On examination, she has jugular venous distension and bilateral lower extremity edema. Echocardiography reveals a reduced ejection fraction of 30% with left ventricular dilation and mitral regurgitation. What is the most likely diagnosis? A. Restrictive cardiomyopathy. B. Dilated cardiomyopathy. C. Coronary artery disease. D. Hypertensive heart disease. Answer B. Dilated cardiomyopathy. Explanation: this patient with progressive shortness of breath, signs of right-sided heart failure, jugular venous distension, edema, and a dilated left ventricle on echocardiography most likely has dilated cardiomyopathy. It is often associated with a reduced ejection fraction and may be related to underlying conditions such as hypertension, diabetes, or obesity. Restrictive cardiomyopathy typically involves diastolic dysfunction with preserved ejection fraction. Coronary artery disease can cause heart failure but is less likely given the presentation. Hypertensive heart disease typically presents with left ventricular hypertrophy and diastolic dysfunction rather than left ventricular dilation. Question 26. A 50-year-old man with a history of hypertension and hyperlipidemia presents with a 3-month history of worsening fatigue, weight gain, and cold intolerance. He reports constipation and hoarseness. On physical examination, his blood pressure is 145/9 mmHg and his pulse is 55 bpm. He has dry skin, brittle nails, and delayed reflexes. Laboratory tests reveal an elevated TH and low free T levels. What is the most likely diagnosis? A. Hypothyroidism. B. Hyperthyroidism. C. Addison's disease. D. Cushing's syndrome. Answer A. Hypothyroidism. Explanation: this patient's symptoms of fatigue, weight gain, cold intolerance, constipation, and hoarseness, along with signs like dry skin, brittle nails, and delayed reflexes, are consistent with hypothyroidism. The elevated TH and low free levels confirm the diagnosis. Hypothyroidism would present with weight loss, increased heart rate, and heat intolerance. Addison's disease would present with hyperpigmentation and electrolyte imbalances, while Cushing's syndrome typically causes weight gain, but it is associated with central obesity, thin skin, and moon face. Question 27. A 65-year-old woman with a history of osteoporosis presents with a sudden onset of severe back pain following a fall. She is unable to move her legs and has no sensation below the level of T. An MRI of the spine shows a compression fracture of the vertebral body at T, with evidence of spinal cord compression. What is the most appropriate next step in management? A. Immediate surgical decompression. B. High-dose corticosteroids. C. Immobilization and observation. D. Intravenous bisphosphonates. Answer A. Immediate surgical decompression. Explanation. Is patient presents with a sudden onset of back pain and neurological deficits following a fall which suggests spinal cord compression due to a vertebral fracture. Immediate surgical decompression is often required to relieve pressure on the spinal cord and prevent permanent neurological damage. High-dose corticosteroids are not recommended for spinal cord injury management. Case, immobilization and observation are insufficient given the acute presentation, and bisphosphonates are used for osteoporosis prevention but are not appropriate in the acute management of spinal cord compression. Question 28. A 45-year-old woman presents with abdominal pain, bloating, and changes in bowel habits. She has a history of intermittent diarrhea and constipation. On examination, her abdomen is tender to palpation, but there is no rebound tenderness. Laboratory tests, including complete blood count and electrolytes, are normal. A colonoscopy reveals no abnormalities, but biopsies show lymphocytic infiltration of the colon mucosa. What is the most likely diagnosis? A. Irritable bowel syndrome (IBS). B. Celiac disease. C. Microscopic colitis. D. Inflammatory bowel disease (IB). Answer. C. Microscopic colitis. Explanation. Is patient presents with chronic abdominal pain, bloating, and changes in bowel habits which are suggestive of a functional gastrointestinal disorder. The colonoscopy findings of normal mucosa with lymphocytic infiltration on biopsy are characteristic of microscopic colitis, a condition that can cause diarrhea and abdominal pain. Irritable bowel syndrome (IBS) typically lacks objective findings on colonoscopy and biopsy. Celiac disease would show villus atrophy on biopsy, and inflammatory bowel disease would present with mucosal abnormalities on colonoscopy. Question 29. A 70-year-old man with a history of diabetes, hypertension, and chronic kidney disease presents with generalized pruritus and fatigue. His laboratory results show an elevated serum creatinine of 3.5 mdl, baseline 1.2 mdl, and a low hemoglobin level. What is the most likely cause of his symptoms? A. Uremic pruritus. B. Chronic liver disease. C. Drug reaction. D. Hypothyroidism. Answer A. Uremic pruritus. Explanation. This patient with chronic kidney disease and a recent increase in serum creatinine has developed generalized pruritus, which is a classic symptom of uremic pruritus. It is a common manifestation of end-stage kidney disease, often associated with elevated serum creatinine levels and uremia. Chronic liver disease could cause pruritus, but would also be associated with jaundice or other liver-related signs. Drug reactions usually present with a rash, and hypothyroidism could cause pruritus, but is less likely in the context of significant kidney dysfunction. Question 30, scenario-based. A 45-year-old man presents with a 6-week history of progressive cough, hemoptysis, and weight loss. He has a history of smoking and worked as a coal miner for 15 years. His chest x-ray shows a mass in the right lung with spiculated borders. What is the most likely diagnosis? A. Pulmonary tuberculosis. B. Lung cancer. C. Sarcoidosis. D. Pulmonary embolism. Answer. B. Lung cancer. Explanation. This patient's symptoms of progressive cough, hemoptysis, weight loss, smoking history, and spiculated mass on chest x-ray are highly suggestive of lung cancer, particularly non-small cell lung cancer (SLC). Sarcoidosis typically presents with bilateral hilar lymphadenopathy and does not usually cause hemoptysis or spiculated mass. Pulmonary tuberculosis could cause weight loss and cough, but it would more likely present with bilateral infiltrates or cavitary lesions. Pulmonary embolism usually causes acute dyspnea and pleuritic chest pain rather than achronic cough with hemoptysis.